Welcome to Mudaliar and Menon Clinical Obstetric Lecture Series. So today we are going to learn an important chapter number 20, which is ectopic pregnancy. So let's dive into the chapter now. Now first, what is the definition of ectopic pregnancy? So any implantation of fertilized ovum or zygote outside the uterine cavity or at an abnormal location within the uterus is known as ectopic pregnancy. So normally, where does the implantation occur? So normally, implantation occurs usually in the upper posterior part of the uterus. This is normally. Now, if there is implantation of fertilized ovum or zygote outside the uterine cavity, outside means it can be fallopian tube, it can be ovary, it can be abdominal cavity, it can be anything outside the uterine cavity or at an abnormal location within the uterus. So even within the uterus, okay, so even within the uterus, if it is somewhere here in the angle of uterus or in the cervix, also this refers to implantation. This is the perfect definition. Implantation of fertilized ovum or zygote outside the uterine cavity or at an abnormal location within the uterus is known as ectopic pregnancy. Now, let's look at the sites of ectopic pregnancy. Now, in fallopian tube is the most common site, MCQ. Okay, fallopian tube is the most common site, and among fallopian tube, there are many parts of fallopian tube, right? So I'm drawing you, this is the uterus, this is your fallopian tube, and this is your fimbriae. So I'm going to label the parts for you. This one over here is your fimbriae, and this one over here, the widest portion is your ampulla, and the narrowest portion over here is your isthmus, and this part over here is your intramural part or your interstitial part. Okay, both are same, intramural or interstitial. Now, amongst this, the most common site in fallopian tube where ectopic pregnancy takes place is going to be your ampullary junction, the widest portion, and the next one is going to be your isthmus. So first is ampullary. Most common site in fallopian tube is ampullary, following which it is your isthmus. Following isthmus is going to be your fimbriae. Following fimbriae is going to be your intramural part. So which is the least common? So the least common site of fallopian tube is going to be your interstitial portion, especially the cornual end. Okay, that is your cornual region. Now, next is ovarian ectopic is rare. Cervical ectopic is more rare. Ectopic in cesarean scar section and abdominal pregnancy. So what are the various sites of ectopic pregnancy? Let's talk in order. First is your fallopian tube. In fallopian tube, ampullary is the most common. After ampullary, it is your isthmus. After isthmus is going to be your fimbrial end. After fimbrial end is going to be your interstitial portion. After fallopian tube, you are going to have your ovarian ectopic and cervical ectopic and ectopic in cesarean section and abdominal pregnancy. So these are the 1, 2, 3, 4 and 5. All these 5 sites of ectopic pregnancy is very important. Now look at this image. This is your uterus. This is your fallopian tube. Now in the fallopian tube, the narrowest is the isthmic ectopic pregnancy. This one denotes your isthmic ectopic pregnancy, or okay, and this one over here is your cornual or interstitial ectopic pregnancy. Okay, this is your cornual or interstitial ectopic pregnancy. In the widest part, you have your ampulla ectopic pregnancy. And in fimbriae, you have your fimbriae or infundibulum ectopic pregnancy. You have your infundibulum here and fimbriae over here. And this is your ovarian ectopic pregnancy. And over here in the abdominal region, you have your abdominal ectopic pregnancy. And over here you have your broad ligament ectopic pregnancy. This is your cervical ectopic pregnancy. So this is a figure that shows various sites of pregnancy, ectopic pregnancy. Now incidence, coming to the incidence, the most common incidence seen is in tubal ectopic pregnancy, as I already mentioned. Then that is around 2 to 2.5%. Then the next common is your ovarian pregnancy. After ovarian pregnancy, it's going to be your abdominal pregnancy, and then your cervical pregnancy and heterotropic pregnancy. Now let's move on to the etiology, which is very important. Now, why does this ectopic pregnancy occur? So first etiology is any congenital or developmental anomaly of the fallopian tube. So suppose say if the fallopian tube congenitally is not well developed, or there is any anomaly or developmental or congenital anomaly of the fallopian tube, then it has a high risk for developing ectopic pregnancy. So this is the first etiology, that is anomalies in the fallopian tube. Second etiology is premature development of the trophoblast. That's very important. So any kind of premature development of the trophoblast will lead to ectopic pregnancy. The third one, tubal infections, very important, and pelvic inflammatory disease. This pelvic inflammatory disease is having a high risk for developing ectopic pregnancy. So tubal infections and the pelvic inflammatory disease is another etiology. Now moving on to the fourth one, periductal adhesions. So if at all there are any kind of adhesions between the fallopian tube and the surrounding structures, then it is also a risk factor for developing ectopic pregnancy, peritubal adhesions. Then the next one, prior tubal surgery is another important high risk factor for developing ectopic pregnancy. Any tubal surgery which is priorly performed, say tubectomy or tubal ligation or any other surgery, okay? So any tubal surgery, it's going to be a risk factor for ectopic pregnancy. The next is a previous history of ectopic pregnancy. So which is the most common etiology, or which is having maximum risk? This is asked in your MCQ. Which is the commonest etiology that is having maximum risk for developing ectopic pregnancy? The answer will be previous history of ectopic pregnancy. So any previous history of ectopic pregnancy is going to have a maximum risk for producing again, right? So the next one is contraceptive use. Contraceptive use includes IUCDs as well as oral contraceptive pills. But remember, more than contraceptive use, it's not that contraceptive use is going to cause ectopic pregnancy. No. Rather, it is the contraceptive failure. Okay. So because of contraceptive failure, especially tubectomy is a high risk factor. So contraceptive failure, tubectomy is going to result in ectopic pregnancy. And then the next one is assisted reproductive techniques. Assisted reproductive techniques. And the next one is condition that is distorting the anatomy of the fallopian tube, such as any tumors that will distort the tube. Example, fundal myoma, any adnexal cysts, and venous suspension with shortening of the round ligament. So I am revising the etiology for you. The first etiology is any kind of congenital or developmental anomalies in the fallopian tube. Next is any premature development of the trophoblast. Third, tubal infections and very importantly pelvic inflammatory disease. Fourth, peritubal adhesions. Fifth is any prior tubal surgery. Sixth is any history of ectopic pregnancy. Seventh, contraceptive failure, especially tubectomy. And eighth is assisted reproductive techniques. Ninth one is conditions that are distorting the anatomy of the fallopian tube, such as tumors in the tube that is going to distort the tube, like fundal myoma or adnexal cysts, okay, or shortening of the round ligament. So these are all the various etiology. Now let's look at the mode of implantation of the ovum in tubal pregnancy. So the mode of implantation of the ovum in tubal pregnancy is fertilization normally takes place where? In the lumen of the fallopian tube and gets implanted on the already prepared endometrium. So this is the normal fertilization. So normally the fertilization takes place exactly where? In the ampulla. Okay, so fertilization occurs exactly in the ampulla of the fallopian tube, and where it is getting implanted? In the endometrium of the uterus. In the endometrium of the uterus, especially upper posterior part of the uterus. Now zygote is going to be arrested in the tube. Say suppose, so for this implantation to act, okay, see what is fertilization? Sperm and ovum is getting fertilized into a zygote. Now this is going to occur in the ampulla part of the uterus. Now for this, okay, so this is the zygote. For this zygote to be getting implanted over here, you need motility, okay, and this motility is given by the sperms, right? It's by the sperms. So if suppose the zygote is arrested in the tube and there is no motility, it will burrow into the wall of the tube. So it is arrested in the tube, that is there is no motility, it burrows into the wall of the tube. Then congestion as well as softening of tissues occurs. Congestion and softening of tissues occurs. Then the ovum gets encapsulated within the muscular tissue. Now this ovum gets encapsulated within the muscular tissue, and you're going to have muscular hyperplasia with no hypertrophy. This is going to be the trophoblastic invasion. And then there is mechanical distension and thinning of the tube and early rupture. Will be there. So again, the mode of implantation of the ovum in tubal pregnancy, it's given in this 6 steps. First, the zygote is going to be arrested into the tube itself, and then burrowing. It burrows into the wall of the tube. Third, there is going to be congestion and softening of the tube. Fourth, the ovum gets encapsulated within the muscular tissue. So within this muscular tissue, the ovum is encapsulated. Then in this muscular tissue, there is going to be muscular hyperplasia, but there is no hypertrophy, only hyperplasia. And also there is going to be trophoblastic invasion. After trophoblastic invasion, mechanical distension and thinning of the tube and early rupture will be there. Now let's look at the changes in the uterus in case of ectopic pregnancy. So what are the changes that you can see in uterus? The first thing is the uterus enlarges, but not to the same extent as an intrauterine gestation. So in intrauterine gestation, normal pregnancy, the uterus is going to be really far more distended. But if in case of an ectopic pregnancy, the uterus is enlarged, but not to the same extent as the normal pregnancy. Now there is going to be a decidual reaction, very important guys. So there is going to be a decidual reaction of the endometrium without any chorionic tissue. That is important. So there will be a decidual reaction where it is going to be in the endometrium. So there is decidual reaction of the endometrium, but there is no chorionic tissue. Chorionic tissue will be absent. Next is, it is expelled as a decidual cast or a piecemeal at the time of termination of ectopic pregnancy. So this is going to be expelled as a decidual cast at the time of the termination of the ectopic pregnancy. Okay, so during the termination of ectopic pregnancy, it will be all these decidual reaction products will be expelled as a decidual cast. Now look at this figure. This figure shows the outcomes of tubal pregnancy. So if you look at the outcomes, there are of the fate of tubal pregnancy or the fate of ectopic pregnancy is mainly two things. One, it can go on to abortion, and the second one, it can go on to rupture. So the main two fate out of for tubal pregnancy or ectopic pregnancy is, one is abortion and another one is rupture. Now see, this is a tubal pregnancy. So there is a embryo in the fallopian tube. Okay, so here you can see. Now this zygote in the tubal pregnancy, or this implanted embryo, can either rupture into the peritoneal cavity or it can rupture into the broad ligaments. So here you will be having your broad ligaments. So it can either rupture into the peritoneal cavity or it can either rupture into the broad ligament. So rupture into the peritoneal cavity can cause severe intraperitoneal hemorrhage, pelvic hematocele, and secondary abdominal pregnancy. So all these three events are very important. So say there is an embryo in the fallopian tube is going to be rupturing. Okay, so ectopic pregnancy in the fallopian tube is going to rupture into the peritoneal cavity. So after it ruptures into the peritoneal cavity, there are three events which can occur. So there can be severe intraperitoneal hemorrhage. It can be very severe. So there is a severe intraperitoneal hemorrhage, then pelvic hematocele, and secondary abdominal pregnancy. Or this embryo can either rupture into the broad ligament. So what will happen if it ruptures into the broad ligament? One is broad ligament hematoma. So broad ligament hematoma can occur. Second is intraligamentous pregnancy. There is intraligamentous pregnancy. And the third one is tubal abortion. So if the products are going to be rupturing into the broad ligament, it can either lead into broad ligament hematoma or intraligamentous pregnancy or tubal abortion. So this is the outcome of the tubal pregnancy. So tubal abortion. So what is tubal abortion and what is the tubal rupture? I told these are the two fates of the ectopic pregnancy. Either it can go to abortion or rupture. Now the products of conception separate from the, okay, what is tubal abortion is, the products of conception will separate from the endosalpinx, okay, from the endosalpinx, and then protrude through the fimbrial end. What is salpinx? Salpinx means fallopian tube, right? So all the products of conception is going to be separating from this endosalpinx, and then it is going to extrude. It's going to extrude or come out. Okay, extrude or come out through the fimbrial end. Complete abortion or incomplete. So tubal abortion can be either complete abortion, or it can be an incomplete abortion. So next is tubal rupture. So in tubal rupture, there is marked increase in the vascularity. Okay. So in tubal rupture, there is a marked increase in the vascularity, where the arteries and veins are all going to be dilated. So in tubal rupture, there is a marked increase in vascularity where arteries as well as the veins are dilated. As well as there is a hypertrophy of the musculature except at the placental side. Also, there is hypertrophy of the musculature except at the placental side. So, tubal rupture, there is a marked increase in vascularity and all these veins and arteries are dilated. So, there is also a hypertrophy of the musculature except at the placental site. Now, in cases where a rupture occurs and only the villi protrude, okay, say suppose rupture occurs and only the villi is protruding, only the chorionic villi is protruding. Okay, so bleeding is going to be there with signs and symptoms of intraperitoneal bleeding and shock. So, bleeding with signs and symptoms of intraperitoneal bleeding as well as shock is going to be there. Complete extrusion of the products. In case of complete extrusion of products will be there, the rent in the tube retracts and the bleeding stops. So in case of tubal rupture, so there will be a marked increase in the vascularity, the arteries and veins are dilated, there is hypertrophy of the musculature except at placental site, and where in a case where it ruptures and only the villi will protrude, bleeding with signs and symptoms of the intraperitoneal bleeding will be there and shock will be there. Complete extrusion of the products means the rent in the tube will be retract and the bleeding stops. Now coming on to the type of tubal gestation and the mode of termination. So we are going to look at the various types of tubal pregnancy or tubal gestation. We already studied this. What are the various ones? The most common one is the ampullary pregnancy. The second most common is going to be the ischemic pregnancy. Then the next is febrile ectopic. And then the last or least common one is the interstitial pregnancy. Now, we will see the mode of termination first for ampullary pregnancy. What will be the mode of termination? Either tubal abortion or either tubal rupture. So these are the only two possibilities for termination. Tubal abortion or tubal rupture. Second one is your ischemic pregnancy. So what is the mode of termination for ischemic pregnancy? The rupture occurs much earlier by say 6 to 10 weeks. Okay. So the rupture occurs much earlier around 6 to 10 weeks of pregnancy and severe intraperitoneal hemorrhage can occur. So severe intraperitoneal hemorrhage can occur. Now say if the fetus is viable even after the rupture. Suppose after rupture the fetus is viable. Then secondary abdominal pregnancy can occur. So after rupture if the fetus is viable, secondary abdominal pregnancy can occur. Next is the tubal rupture. Okay, the tubal rupture may occur between the layers of broad ligament to cause the broad ligament hematoma. So the possibilities for ischemic pregnancy is 6 to 10 weeks. There is rupture and severe intraperitoneal hemorrhage. Secondary abdominal pregnancy can occur if fetus is viable. Tubal rupture can occur especially between the layers of broad ligament leading to broad ligament hematoma. Okay, now we'll move on to febrile ectopic. Febrile ectopic, what is the mode of termination? Complete or an incomplete abortion. Okay, under interstitial pregnancy, the rupture occurs around. So for interstitial pregnancy, rupture occurs around much later. Earlier is for ischemic. Okay, in early ischemic, the rupture is going to be earlier. That is around 6 to 10 weeks. But in interstitial pregnancy, the rupture is going to be late. Okay, so how to remember this is, see, isthmus is the most narrowest, right? And whereas interstitial, there is going to be uterine muscles also involved. So it can enlarge. Okay, it can enlarge. Because of narrowing, it will rupture soon. That is why early, 6 to 10 weeks. Whereas in interstitial pregnancy, the uterine endometrium muscles are going to be nearby, right? So it can expand more. The fetus size can expand more and then it ruptures. So it ruptures late, around 12 to 14 weeks with again severe intraperitoneal hemorrhage. And pregnancy at the cornual end of the tube may grow into the uterus. This is the reason. See, I am reading the reason. pregnancy at the cornual end of the tube may grow into the uterus and develop as a tubo-uterine pregnancy. So that's the reason. So if at all the pregnancy is in the corner of the tube, it can grow into the uterus and result in tubo-uterine pregnancy. Very rarely it gets aborted into the uterine cavity. It's very rare. Now let's look at the clinical features of tubal pregnancy. So what are all the symptoms of tubal pregnancy? So there is a classic triad of ectopic pregnancy, very important triad for ectopic. So any pregnant, or not only pregnant, any lady, okay, any women coming with these three symptoms, that is amenorrhea, classic triad, amenorrhea, abdominal pain and bleeding per vagina, okay, or vaginal bleeding. So amenorrhea, abdominal pain and vaginal bleeding, you have to suspect for ectopic pregnancy. So the classic triad of ectopic pregnancy is amenorrhea, abdominal pain and vaginal bleeding. Now there are other symptoms also which can be associated due to the rupture and abortive symptoms. So if you look at the other symptoms, it can be dizziness or weakness, fever, vomiting. This is all general symptoms. Syncope, cardiac arrest, symptoms of shock in acute rupture, shoulder pain. That too, it is a referred shoulder pain. So I will explain why shoulder pain is occurring. So just shoulder pain will be referred because, see, there is rupture. Rupture can lead to intraperitoneal hemorrhage. So when there is an intraperitoneal hemorrhage, just blood in the peritoneum, so blood in the abdominal cavity will be irritating the diaphragm. So what will happen if the diaphragm is irritated? So if the diaphragm is irritated, then from diaphragm there is a referred pain into the shoulder. Okay, so this referred pain to the shoulder, okay, this is very important. So this sign, referred shoulder pain, this sign is known as Danforth sign. Okay, this is an important sign because of rupture. And urge to defecate. So these are all the general symptoms that we saw in tubal pregnancy. But remember the classical triad. So now I am going to explain to you the signs. First sign is, because of rupture, there is going to be hypotension. Okay, rupture leads to hypotension and tachycardia. So pulse rate will be increased. Okay, so pale and tachycardic. Next is the temperature may be low. So the temperature may be low. The third one is abdominal rigidity and guarding is a very, very important feature. So abdominal rigidity and guarding is an important sign. Then shifting dullness can be present. Cullen sign. What is Cullen sign? Bluish discoloration around the umbilicus. Bluish discoloration around the umbilicus is known as Cullen sign. What is Turner sign? Turner sign is bluish discoloration in the flanks. So pale, tachycardic, temperature low, abdominal rigidity and guarding, shifting dullness, Cullen sign, Turner sign. All of this is going to be very important signs that you can see in a case of tubal pregnancy. Under vaginal examination, there is a bulge of fullness in the posterior vaginal fornix. Okay, so that is the pouch of Douglas is going to be boggy because of the, see, there is intraperitoneal hemorrhage due to which the pouch of Douglas is boggy. So that because of the bulge, okay, bulge or the fullness in the posterior vaginal fornix can be seen. And movement of the cervix, very important. Movement of the cervix causes or aggravates the pain. Okay, So movement of the cervix causes or aggravates the pain. That is known as cervical motion tenderness. So just cervical motion tenderness means when you are moving the cervix, the patient is going to have tenderness. So this is known as cervical motion tenderness. It is seen in pelvic inflammatory disease and ectopic pregnancy. I already explained you the Danforth sign, that is the referred shoulder pain due to intraperitoneal or blood in the abdominal cavity. Danforth sign. So along with this, you can see a boggy pouch of Douglas, or the fornix also can be tender. Fornix can be tender. All of this can be the signs in tubal pregnancy. Now, this is a unruptured ectopic. So what is the feature of an unruptured ectopic? So unruptured ectopic will present us only with the history of amenorrhea. So in 70 to 80% of cases with unruptured ectopic, it is going to be the history of amenorrhea. On and off irregular spotting can be seen, very very important. On and off irregular spotting, and the patient may present with a vague colicky pain on the affected side due to stretching of the broad ligament as well as the tube. So why the patient is having this vague colicky pain? Because of the stretching of the broad ligament and the tube. So next, the patient may develop malaise, discomfort as well as uneasiness. Remember, unruptured ectopic, the main complaints is amenorrhea and on and off irregular spotting is the main feature. Irregular spotting. Now let me look at let us see the clinical features of an unruptured ectopic pregnancy. So the clinical features are: before the rupture of ectopic pregnancy, the blood pressure and the pulse rate may be normal, or they may be slight tachycardic. So only after rupture the BP and pulse rate will be abnormal, but just before the rupture the BP will be normal and there may be mild slight tachycardia. And on abdominal examination, on deep palpation especially, there may be tenderness on the affected side. Very very important sign. So if the ectopic pregnancy is unruptured and you are doing the abdominal palpation, then the patient will have tenderness on the affected side. Then the uterus might be slightly enlarged. So the uterus, if you look at the uterus, it may be slightly enlarged, but not up to the enlargement in a normal pregnancy where it is far more enlarged. Now a tender unilateral pulsatile mass, very important. A tender unilateral pulsatile mass may be palpable on one side or in the pouch of Douglas. Very important. So a tender unilateral pulsatile mass may be palpable on one side or in the pouch of Douglas. Next is a positive cervical excitation. As I already told you, cervical motion tenderness can be there. A positive cervical excitation is there. Now let's look at the diagnosis of ectopic pregnancy. How are we going to diagnose ectopic pregnancy? So first is culdocentesis. So what is culdocentesis? Basically we are going to put a needle and we, in the pouch of Douglas, and we are going to remove all the blood that is collected in the pouch of Douglas after rupture. So this is culdocentesis. So the procedure is involved inserting a wide bore needle through the posterior fornix into the pouch of Douglas. Aspirating non-clotting blood is going to be there. So a very very important, aspiration of non-clotting blood is diagnostic of ruptured ectopic. So the point here to be remembering in culdocentesis is aspirating the non-clotting blood. So aspirating the non-clotting blood is going to be diagnostic of a ruptured ectopic. So next is, with the availability of ultrasound, this procedure has now become outdated. So nowadays cultosynthesis is outdated because we have the best one to do, that is ultrasound. Next is serum HCG. So first step in evaluating patients suspected of having an ectopic pregnancy. So if you are suspecting an ectopic pregnancy, the first step is going to be your serum HCG levels. So if the HCG is negative, the test rules out the possibility of any intra or an extrauterine pregnancy. Basically, HCG negative means it rules out pregnancy itself. So this pregnancy, whether it is intra or extra, that we cannot find, but you can obviously rule out pregnancy by serum HCG levels negative. The next very important investigation is transvaginal sonography. Very important, guys. This is the best. Okay, the best investigation. Transvaginal sonography. So the gestational sac, we can see the gestational sac, okay, to be consistently identified as early as 33 to 34 days of conception. Okay. And transvaginal sonography is 96% sensitive and 97% specific for the diagnosis of ectopic pregnancy. Now, the gold standard. So, in MCQ, if they are asking the gold standard for ectopic pregnancy diagnosis is laparoscopy. Because in laparoscopy, you can exactly know the site, everything. So, it is the main use in the management of ectopic pregnancy, laparoscopy. And you can do certain additional investigations like grouping, blood grouping, cross-matching, as well as reserving adequate quantities of blood is also important. In the ultrasound of ectopic pregnancy, there are two classical findings. One is bagel sign. Remember bagel, you know bagel looks like a donut or a vada, that is the shape. So that is bagel sign. Okay, in ultrasound you can see something like this. Okay, like this and this. That is bagel sign. And the next one is a ring of fire. If you are doing a venous Doppler, you can look ring of fire around this. Okay, ring of fire appearance. So just remember these two signs. Bagel sign and ring of fire is seen in ectopic pregnancy ultrasound findings. Now let's move on to the differential diagnosis. So what is the differential diagnosis of ectopic pregnancy? It can be just a simple pelvic inflammatory disease. The second one to rule out is abortion, especially a threatened or an incomplete abortion. And the next one is ovarian cyst. Ovarian cyst is going to be persistent corpus luteum with a delayed period. Okay, so that is Halban syndrome. On to the differential diagnosis of ectopic pregnancy, we have pelvic inflammatory disease, abortion threatened or incomplete, ovarian cyst, especially ovarian cyst is generally associated with Halban syndrome. What is Halban syndrome? Whenever there is a persistent corpus luteum with delayed periods, that is known as Halban syndrome. So any persistent corpus luteum with delayed periods is Halban syndrome. The next one is rupture of follicular or corpus luteum cyst. Acute appendicitis can mimic ectopic pregnancy. Rupture of an endometriotic cyst. Dysmenorrhea, bleeding episode of abnormal uterine bleeding and renal colic. So let's look at the management. So under management of ectopic pregnancy, we have medical management, okay, as well as we have surgical management. So when do we do medical management? Only if it is an unruptured. Only if it is an unruptured ectopic pregnancy, we will have the medical option. Whereas for a ruptured ectopic pregnancy, definitely we have to go for surgery. So this is the management. So for ruptured, it is going to be surgery. For an unruptured ectopic, it's going to be medical. Now, Now moving on to the medical management. Medical management, we are going to, this is the savior drug for ectopic pregnancy, methotrexate. So if you look at methotrexate, we can also give antimetabolite like the folic acid antagonist. This antimetabolite as well as methotrexate can be given intramuscularly, or it can be injected into an ectopic site under the ultrasound or laparoscopic guidance. Only 25% of cases are suitable for this therapy. So remember, methotrexate injected intramuscularly. Now let's look at the indications for medical management. So what are all the indications for medical management? So the first indication is, as I already mentioned, any unruptured. So you cannot do for ruptured. Only unruptured ectopic pregnancy is an absolute indication for medical management. The size of the mass, if you see, it's going to be usually less than 3 to 4 centimeter. So if at all the size of the ectopic mass is less than 3 to 4 centimeter, then we can manage medically. The very important thing is beta HCG level. If beta HCG level is going to be less than 5,000 micro international unit per ml, then we can do medical management. There should not be any cardiac activity. This is very important indication. So there must be no cardiac activity, as well as there should not be any kind of hemoperitoneum. The patient should be hemodynamically stable. Okay, that's also another important fact. The patient should be hemodynamically stable, and patient should be willing for regular follow-up. Now let's look at the contraindications. Contraindications are, first, beta HCG level that is greater than 5,000 international unit per liter. Fetal cardiac activity present. Free fluid in the cul-de-sac if it is present, or hemoperitoneum is there. Documented hypersensitivity to methotrexate, definitely. If there is hypersensitivity to methotrexate, we cannot administer methotrexate. Breastfeeding is very important contraindication. Immunodeficiency, liver disease, blood dyscrasias including thrombocytopenia, anemia, active pulmonary disease, as well as an acid peptic disease. These are all the contraindications for medical management in ectopic pregnancy. Now, coming to a very, very important topic which you must remember in the management is single dose regimen. As I already told you, this life-saving drug in ectopic pregnancy is your methotrexate injection. So that is going to be your single dose regimen. So I am going to classify it as like day 1 what I am going to do, day 4 what I am going to do, and day 7 what I will be doing. So day 1 I will be injecting the methotrexate, okay, in deep intramuscularly. Injection methotrexate is going to be, the dose is 50 milligram per meter square of body surface area. Very important. So on day 1 I am injecting methotrexate intramuscularly. What is the dose? 50 milligram per meter square of body surface area. Now on day 4 what I will be doing is, I am going to measure beta HCG levels. So on day 4 I will be measuring the beta HCG levels, and on day 7 I am going to repeat beta HCG level. Okay, so on day 4 and day 5 I am just going to measure beta HCG levels. Okay, after giving injection methotrexate IM day 1. Now after day 7 repeating beta HCG level, I am going to see whether there is a decrease in the beta HCG level. How much? If the decrease in beta HCG level is more than or equal to 15% of day 4, see, day 4 I will have some X value. Day 7 I will be having some Y value of beta HCG. This Y value, okay, this Y value of beta HCG that I am measuring on day 7 must decrease, must be less than or equal to at least 50% of the X value. Okay, it should be less. Therefore, it indicates response to treatment. Why it is important? We are looking for the response to the treatment. So you need to repeat beta HCG weekly until it becomes undetectable, that is less than 10 micro international unit per ml. So I am again revising this. So first I am in day 1 I will be giving injection methotrexate intramuscularly. On day 4 I will be measuring beta HCG level and I will get some X value. On day 7 I will again repeat beta HCG level and get some Y value. Now I am going to see. See, if at all the patient is responding very well to the injection methotrexate, it means the beta HCG level is going to be gradually decreasing. I am going to look for the decrease. And if the decrease in the beta HCG level is more than or equal to 15% of day 4 level, then it indicates response to the treatment is good. Okay, and you are going to check this beta HCG level every weekly until it becomes undetectable. Now, if at all the scenario is like the decrease in beta HCG level is less than say 15% of day 4 level. So if the decrease in the beta HCG level is less than 15% of day 4 level, then I'll need to repeat giving the injection. Very important. So if the decrease is going to be less than 15% of day 4 level, I need to repeat injection methotrexate. And on day 14, what I'll be doing is I am going to repeat again beta HCG level, as well as I'll do an ultrasound. If again there is no decrease of beta HCG level from day 7, then definitely surgical intervention is required. So now you understand when the surgery is needed. Just for an ectopic pregnancy, you can't go blindly for surgery. You are going to give single dose regimen, injection methotrexate. You are going to wait for day 4, day 7, as well as if there is no decrease less than 15%, then on day 14 again you are going to repeat and do an ultrasound. And again, if there is no decrease in beta HCG, then only you will be going for surgical intervention. Now, next I am going to introduce to you the multiple dose regimen. So what is multiple dose regimen? Again, methotrexate is given intramuscularly, but the dose is how much? 1 milligram per kg. Okay, so methotrexate 1 milligram per kg intramuscularly on all the odd days. What are the odd days? 1, 3, 5 and 7. The next drug I am going to give is leucovorin. Okay. Okay, so you all know that the methotrexate is generally an anti-metabolite. And what is this leucovorin for? What is leucovorin? Leucovorin is a drug which is going to be preventing from the harmful effects. Okay, it prevents or it gives protection from the harmful effects of the methotrexate. That is why it's given in combination. It's a multiple dose regimen, methotrexate. Okay, so remember, methotrexate is 1 milligram per kg IM on all the odd days, whereas leucovorin is 0.1 mg per kg again IM on all the even days, that is 2, 4, 6, 8. Now we are going to look for the beta HCG level, and this beta HCG level should be checked every 48 hours until it decreases by 15%. Then you are going to be checking it weekly. So every 48 hours, that is every 2 days, we are going to look for beta HCG level, and until it decreases by 15%, and after then we will be checking it weekly. No response. If there is no response to this multiple dose regimen, then surgical intervention or a second course should be attempted. Now let's move on to the surgical management. What are the indications of surgical management? First is hemodynamically unstable patient. So the first indication, any hemodynamically unstable patient, you're going to surgically intervene the patient. So medical management will not be sufficient. Hemodynamically unstable patient with a tubal rupture. Stable. See, any hemodynamically unstable patient, definitely surgery. If the patient is hemodynamically stable, but the patient is having tubal rupture or abortion as evidenced by hemoperitoneum on ultrasound, then again we are going to go for surgery. Methotrexate is absolutely contraindicated. Okay, if at all methotrexate is contraindicated, definitely you can't do anything, right, with medical management, because the savior drug is methotrexate. So definitely you're going to go for surgery if methotrexate is contraindicated in the patient. Then heterotropic pregnancy with a coexisting viable intrauterine pregnancy. So there is a ectopic or heterotropic pregnancy, but it is also coexisting with a normal intrauterine pregnancy. then you cannot give methotrexate because of its harmful side effects. So you are going to go for surgery. When medical management of the unruptured ectopic has failed. So in unruptured ectopic, if the medical management has failed, you are again go for surgical management. In the management of ovarian pregnancy, secondary abdominal pregnancy and interstitial pregnancy. Okay, so in any management of ovarian pregnancy or secondary abdominal pregnancy as well as interstitial pregnancy, definitely surgery is opted. Now let's look at the approach of this surgery. So the main approach of surgery in ectopic pregnancy will be laparotomy or laparoscopy. Very important. Laparotomy or laparoscopy is our approach to this surgery. So what are the methods? The various methods is salpingectomy or any conservative methods like salpingotomy. Salpingectomy, that is removal of the fallopian tube, is quite invasive. So we also have other options, other conservative methods. Now we are moving on to autotransfusion. So autotransfusion means blood is going to be from the peritoneal cavity collected in a sterile solution containing 2% of sodium citrate, which is filtered as well as transfused, and it's useful in situations where appropriate blood is not available. So there will be some situations where the appropriate blood is not available. In such situations, what they will do is the blood from the peritoneal cavity will be collected in a sterile solution containing 2% sodium citrate, filtered, and then it will be transfused, and this is known as autotransfusion. Now, moving on to salpingectomy. So what are all the indications of salpingectomy? So the indications for salpingectomy are the women who do not wish to have any more children is an indication. Tubal rupture with moderately or severely damaged tube is another indication. Inability to control the bleeding at conservative surgery. If during conservative surgery the bleeding is uncontrollable or unable to control, then we are going to do salpingectomy. When the site of the ectopic site is going to be more, when the size of the ectopic site is more than 3 to 4 centimeter, then again salpingectomy. When there is recurrent ectopic pregnancy on the same site, also we need to go for salpingectomy. So these are the indications for salpingectomy. So let's look at the procedure. So the abdomen will be opened and the ectopic side, first the side is going to be identified, and the tube is going to be lifted with the fingers, and then clamps are going to be applied on either side of the ectopic on the mesosalpinx, one finger on the mesosalpinx, another one at the uterine end. Then the abdomen is going to be cleared of blood. Total salpingectomy is generally preferred. And the removed portion, the removed portion of the tube is going to be sent for histopathological examination to confirm an ectopic and any other underlying cause such as tuberculosis. Now, what are the other options? Conservative surgical procedures. So, conservative surgical procedures are opted when the patient desires to conserve her fertility. So, when the patient wants to conserve her fertility, then we are going to move on for the conservative surgical procedure. When the patient is hemodynamically stable, we can perform. The gestational sac is going to be unruptured and should be less than 5 cm in size. So for a conservative surgery like salpingotomy to be done, these are the 3 indications. The patient desiring to conserve her fertility, hemodynamically stable, gestational sac is unruptured and less than 5 cm in size. Next, moving on to salpingotomy. So how are you going to do salpingotomy? An incision is made in the anti-mesenteric surface of the tube. The ectopic contents are shelled out gently and hemostasis obtained with electrocoagulation and fine. So therefore, following surgery, serial weekly measurement of HCG is going to be definitely important. So beta HCG levels must be are very important. And methotrexate can be administered, especially what is the dose? As I already told you, 50 milligram per meter square. If the level fail to decrease is expected. Okay. So now, if the pregnancy is in the isthmus, then rupture is more probable. So in such cases, we are going to opt for resection and end-to-end anastomosis. Very important. When there is rupture and pregnancy is in the isthmus, resection and end-to-end anastomosis is done. Also, when the bleeding is going to be heavy and the tube needs to be preserved, resection and end-to-end anastomosis is done. Now, pregnancy in a rudimentary uterine horn. Now, let's move on to this topic, a new topic, that is pregnancy in rudimentary uterine horn. So, during development, the uterus develops into two horns and fuses. In some conditions, there may be only one well-developed horn, okay, with other horn being rudimentary, which may or may not be communicating also. Occasionally, a fertilized ovum migrates into gist sac, and gist sac is known as false decidua. Very important. Gist sac is known as false decidua, and this false decidua in the uterine cavity proper, therefore the uterus size also increases. So as the muscular tissue of the horn is going to be poorly developed and cannot keep pace with the progressively enlarging ovum, rupture occurs within the first 16 weeks of pregnancy. So rupture occurs within the first 16 weeks of pregnancy. Okay. And how will you diagnose? Diagnosis is by a pulsating mass. Very important. A pulsating mass corresponding to the size of duration of pregnancy is detected alongside the slightly enlarged uterus. The possibility of pregnancy is going to be a rudimentary horn is going to be suspected. So when will you suspect for a rudimentary horn? When there is a pulsatile mass that is corresponding to the size during the pregnancy, which is detected alongside the slightly enlarged uterus, then you'll be suspecting a rudimentary horn pregnancy. So what is the treatment? The treatment is removal of the pregnant horn. So the pregnant horn entirely should be removed, as well as conserving the main body of the uterus if possible. So this is a laparoscopic appearance of rudimentary horn pregnancy. So just what you are seeing here is a laparoscopic appearance of a rudimentary horn pregnancy. Now moving on to the abdominal pregnancy. So primary implantation of the fertilized ovum on the peritoneum is actually extremely rare. So primary implantation is very rare, but a secondary implantation, okay, that is secondary to early rupture of tubal pregnancy. See, because there is a rupture of tubal pregnancy, just may go and implant in the abdomen. That is the reason secondary implantation is very common as compared to primary implantation, where it is secondary to the early rupture of a tubal pregnancy into the peritoneal cavity. Now, after penetrating the tubal wall, it maintains its tubal attachment but gradually encroaches upon and implants in the neighboring serosa, and the fetus continues to grow in the peritoneal cavity. Rarely, abdominal pregnancy may result from the silent dehiscence of a classical caesarean scar. So primary abdominal pregnancy is generally diagnosed by a criteria, very important. In MCQ they can ask, this can be an MCQ. Primary abdominal pregnancy is diagnosed by which criteria? The criteria name is Studyforth's criteria. What is the criteria? Studyforth's criteria. So the primary abdominal pregnancy is diagnosed by Studyforth's criteria. So presence of normal tubes as well as ovaries with no evidence of recent or past pregnancy is there, and no evidence of uteroplacental fistula. The presence of pregnancy related exclusively to the peritoneal surface and early enough to eliminate the possibility of secondary implantation after primary tubal nidation. Now moving on to the clinical features. So first one is history suggestive of any tubal pregnancy. So clinical feature is first history suggestive of tubal pregnancy. Nausea, vomiting, flatulence, constipation, diarrhea and abdominal pain may each present in varying degrees. Late in pregnancy, the fetal movements can be felt with great ease as well as these movements are painful. Okay. Now Braxton Hicks contractions are generally absent. Very important. So clinical feature in ectopic pregnancy, Braxton Hicks contractions are not going to be there. They are absent. Okay. They won't be there. On pelvic examination, the cervix is usually going to be displaced and the presenting part is usually going to be high. And then fetal heart sounds, if present, are going to be generally superficial. So now in an ultrasound examination, okay, in your so a case of ectopic pregnancy and you're doing the ultrasound examination, what all will be the finding? First is there is no clear uterine shadow. So in an ectopic pregnancy ultrasound, the uterine shadow will not be clear because there is no clear uterine shadow around the gestational sac. Very important. So there won't be any kind of uterine shadow around the gestational sac, and the uterus may be seen as a separate mass. The uterus itself can be seen as a separate mass. And absence, there is going to be absence of the myometrial tissue between the bladder as well as the pregnancy. So absence of myometrial tissue between bladder and pregnancy. And moving on to X-ray examination, a lateral view shows fetal parts overlying the maternal vertebra. So a lateral view will be showing all the fetal parts that are overlying the maternal vertebra. Now moving on to treatment. First is surgery is the only treatment for abdominal pregnancy. Okay, so in an abdominal pregnancy, surgery is the only and main treatment. So what are the principles of surgical management for abdominal pregnancy? First is cross-match blood, management of placenta. The best policy is to avoid any unnecessary exploration or remove the fetus, tie the cord close to the placenta and close to the abdomen. So what are the best policy? To avoid unnecessary exploration, remove the fetus, tie the cord close to the placenta and close the abdomen. Good antibiotic cover and methotrexate should be done. So good antibiotic cover and methotrexate is given. Uterine artery embolization is also done. So these are the principles of surgical management in case of abdominal pregnancy. Maternal mortality and morbidity is going to be generally increased. Fetal salvage in an abdominal pregnancy is exceedingly precarious and the great majority die even prior to removal or in the neonatal period. Okay, so fetal salvage in an abdominal pregnancy is very exceedingly precarious because they all die, okay, prior to the removal itself. And incident of congenital malformations is also higher in such pregnancy. Now moving on to the next one, that is ovarian pregnancy. So primary ovarian pregnancy is very rarest type of extrauterine pregnancy, very rare, and 3% of all the ectopics. Okay, so ovarian pregnancy constitutes 3% of all ectopics with an incidence of 1 in 25,000 to 4,000 pregnancies. Fertilization occurs where in the Graafian follicle. So fertilization occurs in the Graafian follicle and the fertilized ovum gets implanted directly into the ovarian tissue. So fertilization occurs if the Graafian follicle and the fertilized ovum gets implanted directly into the ovarian tissue. Final diagnosis is made at laparotomy or as well as by histopathology. That is the final diagnosis. So in this figure you can see ovarian pregnancy with a normal fallopian tube. Now moving on to a special criteria in ovarian pregnancy. So for abdominal pregnancy, what was the criteria for abdominal pregnancy? It was Study Ford's criteria. Now for ovarian pregnancy, you have a special criteria known as Spiegelberg criteria. Okay, Spiegelberg criteria. So what is this Spiegelberg's criteria? The fallopian tube on the affected site must be intact. The gestational sac must occupy a portion of the ovary, and there should be no separate ovary on the affected site. And the gestational sac must be connected to the uterus by the ovarian ligament. So the gestational sac must be connected to the uterus by the ovarian ligament. A histological examination must reveal the presence of definite ovarian tissue in the wall of the gestational sac. So the Spiegelberg's criteria for ovarian ectopic pregnancy is: first, the fallopian tube on the affected site should be normal. Second is the gestational sac should occupy the position of the ovary, and there should be no separate ovary on the affected side. The third is the gestational sac must be connected to the uterus by a ovarian ligament. Then the fourth is a histopathological examination reveal the presence of definite ovarian tissue in the wall of the gestational sac. Now, next moving on to cervical pregnancy, again rare. The endocervix is going to be eroded by trophoblast. Very important. In cervical pregnancy, the endocervix is going to be eroded by the trophoblast. And the duration of pregnancy depends upon the site of the implantation. Very important. So the duration of cervical pregnancy always depends upon the site of implantation. And painless vaginal bleeding. Okay, painless vaginal bleeding occurs, and at times there is also massive hemorrhage. Diagnosis is made on ultrasound examination when the uterus is going to be seen to be empty. So there is an empty sign in the uterus, and a gestational sac is going to be seen in the cervical canal. That is the diagnosis being made by ultrasound. And the treatment is again surgical treatment. However, medical treatment with methotrexate or injection of potassium chlorate in the gestational sac have also been tried, but surgical is the best one for cervical pregnancy. And cervical pregnancy, what is the criteria? See, for abdominal pregnancy it was Studyford's criteria. For ovarian pregnancy it was Spiegelberg's criteria. And for cervical pregnancy it's going to be Rubin's criteria. Very important, Rubin's criteria. Okay, Rubin's criteria. So the uterus in Rubin's criteria, what it says is, first is the uterus is going to be smaller than the distended cervix. That's the main clue. So because it's a cervical pregnancy, the cervix will be distended as more compared to the uterus. Next is the internal os is not dilated. Very important, in cervical pregnancy the internal os will not be dilated. In third one is external os opens earlier than it does in spontaneous abortion. So very important, the third point is external os opens earlier. Okay, so an external os will be opening earlier, and also it does not, and it does in spontaneous abortion. External os opens earlier than it does in any case of spontaneous abortion. Then curettage of the endometrial cavity is non-productive of placental tissue. So curettage of the endometrial cavity is going to be non-productive of placental tissue. Next, moving on to cesarean scar ectopic pregnancy. So since cesarean scar ectopic pregnancy is again the rarest of all the ectopic pregnancy, again an important PYQ, which is the very least common or rarest ectopic pregnancy is cesarean scar. So here the blastocyst gets implanted, okay, in say microscopy or macroscopy tract of the uterine scar. So the blastocyst is implanted in the uterine scar or in the niche or dehiscence left behind by previous cesarean delivery. So what are the ultrasound features? An empty uterine cavity, very important. So ultrasound features, you will be having an empty uterine cavity as well as an empty endocervical canal, and chorionic or gestational sac or placenta. So either chorionic or gestational sac or placenta located low in the anterior wall of the uterus. Okay, Chorionic or gestational sac or placenta is going to be located low in the anterior wall of the uterus, below the bladder, in close proximity and at the level of internal os, at the site of previous hysterectomy, scar or niche, with or without fetal or embryonic pole, or yolk sac, and with or without heartbeat. So that is the ultrasound features in cesarean scar ectopic pregnancy. Okay, so you'll be having empty uterine cavity or an empty endocervical canal. Chorionic or gestational sac or placenta will be located in the anterior wall of the uterus, below the bladder, and at the level of the internal os, at the site of previous hysterectomy or scar. Okay, in the site of previous hysterectomy scar. Now, what is the treatment? The treatment is medical, surgical, and less invasive methods. Systemic or intragestational injection of methotrexate is very important. Systemic or as well as intragestational injection of methotrexate can be given. Minimally invasive methods such as uterine artery embolization. Okay, uterine artery embolization can be done. Surgical options include hysterectomy, excision, and suction aspiration. So what is heterotrophic pregnancy? What do you mean by heterotrophic pregnancy? A tubal gestation is sometimes associated with an intrauterine pregnancy. Sometimes a tubal gestation also will be associated with a normal intrauterine pregnancy, and this is known as heterotrophic pregnancy. So that is more than one. Okay, heterotrophic pregnancy, more than one kind of pregnancy. That is, one is tubal pregnancy, another one is intrauterine pregnancy. Common with assisted reproductive techniques. Very important point. It is common with assisted reproductive techniques. And ultrasound is used for diagnosis here. So what is used for diagnosis? Ultrasound is used for diagnosis. And after excision of the extrauterine pregnancy, in most instances, the intrauterine pregnancy continues to grow without any much of complication. So our target for heterotrophic pregnancy is just to do the excision of the extrauterine pregnancy, whereas the intrauterine pregnancy can continue because mostly without any much complications. Yeah, so thank you. If you like this video, please do like, subscribe, and share this channel with all your friends and who are especially studying, who are in final year. And if you want to know more chapters in you can see the entire series of Mudaliar Menon lectures, obstetric series, and other topics also in medicine. Thank you.